Hello, guys. Welcome to Man Medicine, where we talk about how men can optimize their health and escape the collapsing U.S. healthcare system. Today, we're going to do a little Q&A. So I've got some questions lined up here that you guys have sent me, which I greatly appreciate. You guys, again, you always ask really good questions. So I've tried to answer as many of them as I can without making this episode too long. So I apologize. I'm a little under the weather today. I had a late shift last night at the hospital. I didn't get home till about 3 in the morning, and it's about 10 a.m. here now in UAE. And man, it was a butt kicker. So shift work is rough, man. It's rough no matter what age you are. But when you get above 50, like these day shifts, night shifts, late evening shifts, like they start stacking up. And I'll tell you, the last 3 weeks, I've just been getting my ass handed to me basically at work. So that's why I haven't put out a video for you guys. I've been like either working, recovering from work, or getting ready to go right back to work, and then like trying to spend time with my wife and my kids. And like, it's challenging, man. It's challenging. But anyway, there's some things in the works. Nothing that I can announce to you guys anytime soon, but maybe soon. I don't know. We'll see. That things may be looking up here. So more on that a little bit later. So yeah, why don't we just dive into these questions? So there's not really in any particular order. I just kind of like went through my comment section and I pulled out the ones that I thought were particularly good. And again, I've said this before, but just because I didn't put your particular question in here, it doesn't mean it wasn't a good question. It's like I've got to make some cuts on these, or else we'll be here for like two or 3 hours. So yeah, there's no particular theme with any of these. They're all kind of random all over the place. And so I'm going to give you kind of my take and my off-the-cuff responses to these questions. So, all right, number one. Okay, this one is interesting. So I'll put it up here on the screen. The other common use case for Nandrolone is for men on TRT with BPH or concerned about the inevitable development of BPH. So I'll just say right there, like that's not a common use case for Nandrolone at all. I don't know any physicians or any clinics that recommend using Nandrolone to offset BPH. But, as I read the rest of the question, I can totally understand why you might be led to the conclusions that you were led to. It makes sense mechanistically. But let me give you my take on this and why I don't think that this is an approach that's going to be effective at all if you have BPH. So let me continue. Reducing the dose of testosterone and replacing it with a like amount of Nandrolone will maintain the benefit of higher dose testosterone. Okay, it doesn't, while sparing the prostate due to dihydronandrolone being much weaker agonist for the AR than DHT. So that is true. 5-alpha reductase, it converts nandrolone to DHN or dihydronandrolone. And yeah, like dihydronandrolone is, it's like 10-20% of DHT's activity when it comes to like its ability to stimulate the androgen receptor. So that it would kind of make sense. Maybe you would get less prostatic hypertrophy if we used, or if it was exposed to dihydronandrolone instead. So, you can't use, or you shouldn't use Nandrolone only for TRT. Like that's a terrible idea for a lot of different reasons that I won't get into. So you always have to use it with testosterone if you're going to use it at all. And that's a different conversation. We'll maybe address that in one of these later questions. But let's continue. Most of the men in the age group concerned about BPH will also likely derive additional benefit from Nandrolone substitution with regard to joint pain. I've talked about that. I'm going to talk about that a little bit more in this Q&A, but yeah, I mean, there is data on it. I've used it myself, and joint pain, arthritic pain, etc. Few older men do not have both BPH and osteoarthritis. Yeah, I mean, that's probably true, at least to some degree. This may be an ideal combination for many of them. So let me tell you why it's not an ideal combination. So, and again, it has to do with, this gets back to the saturation point of the androgen receptor in prostatic tissue in the prostate. So essentially, we know this from the prostate cancer literature, serum testosterone levels, total serum testosterone levels above somewhere like 200 to 250, you have saturated all of the androgen receptors with testosterone. And so the amount of hyperplasia you're going to get is maxed out at that very low serum testosterone level. So any amount of testosterone that you give in terms of replacement above that is you will saturate the androgen receptor. And, there's going to be some competition with dihydronandrolone along, with DHT. Okay, so maybe we can increase that a tiny little bit. But, the point is, like, any meaningful amount of testosterone is going to convert to DHT, and it's going to maximally stimulate prostatic hyperplasia, regardless of whether you have nandrolone in the background. So, I understand where you're coming from mechanistically here, but the reality is that, like, it just doesn't work that way. And that's why nobody does this. At least nobody should be doing it. I hope there's no physicians out there that are doing that. If they are, they just, like, they don't understand this model. But this is why drugs like nandrolone and, many of these other synthetic androgens were created in the first place, right? Like back in the 50s, 60s, and 70s, as they were trying to minimize the androgenic effects, meaning primarily the effects of DHT, and then maximize the anabolic effects. It was kind of a misguided approach, really, because, the androgenic effects of testosterone are actually generally pretty beneficial. So that's another conversation for another time. But listen, if you have BPH, adding nandrolone and, like, substituting a given percentage of your total androgen load for the week, say, with nandrolone, it's not going to make any difference whatsoever. And you're still going to have BPH. You're still going to have BPH symptoms. We've got good treatments for it. So you're just going to need to have a conversation with your doctor about that. But, like, nandrolone is not the answer to BPH. So I do not recommend that. Okay, next one. I just started HCG. Okay. I came off of TRT 80 milligrams a week for 3 years. Okay, so off the bat, like, that's kind of a low dose, for most guys. There may be guys out there that do well on that, but it's a little bit light. Hypertension got out of control, but I did notice that my blood pressure started raising more when I went from test enanthate to test cypionate. Any notable medical data on this? So first of all, like, if you got out of control high blood pressure on 80 milligrams a week, that's a bit surprising. It's probably not the testosterone, honestly. You need a proper workup by a competent physician, an internist, family medicine doc, cardiologist, etc., to see why is your hypertension now out of control. And maybe it's something obvious, like you've gained 30 pounds of visceral body fat and you eat 25 grams of sodium a day. Maybe it's smoking. I don't know. Maybe it's hereditary. Maybe you have primary aldosteronism, which nobody screens for these days, or even though we're supposed to. So I would not automatically blame the testosterone on this. If you're using HCG monotherapy as your protocol for HRT, leaves a lot to be desired. I don't recommend that. There's not really a use case for that in my opinion. So. But as far as, like, differences between enanthate and cypionate, so anytime I hear this, that somebody feels a certain way or has a certain thing happen to them with enanthate or cypionate, I mean, these are anecdotal stories and I'm not discounting them, but, when you look at literature, like when they compare head to head, and, they've done some of this with, like, the Xiosted studies. This is one here, Journal of Urology, comparison of outcomes for hypogonadal men. They compared intramuscular testosterone cypionate versus the sub-Q enanthate, which is like the Xiosted, the auto injector, which is kind of ridiculous and overpriced, but there are clinics that do use it. Anyway, it's a big randomized trial. Basically, there was no difference. Okay, no difference in terms of like hypertension and a number of other factors, including serum levels, estradiol, etc. So it was kind of a wash. I personally don't really think that there's any meaningful clinical differences between enanthate and cypionate. There are a lot of bros out there that would argue with me on that. And you know what? Like, if you feel better on enanthate than cypionate or vice versa, like, who am I to say you're wrong? Like, you use the one that you feel better on. The pharmacokinetics and whatnot are, for all practical purposes, are identical. So it's up to you. But no, when you actually look at the data, like, there's very little data that I could find. In fact, by little, I mean none, that showed any kind of meaningful difference between the two, like in terms of, like, clinical parameters. So that's how I feel about it. Oh, okay, this one, yeah, post-finasteride syndrome. How does one get a diagnosis for it? There's no formally agreed upon definition of what this is. There's a lot of controversy, actually, in the medical literature about Is there an underlying mechanism? What causes this? Is it even a real condition? Like there are people that think it's not. I happen to think it is a real condition. I would be very arrogant to say that I know what causes it and I know how to treat it. And I would be very wary of any of these bro influencers, tank top wearing dudes that tell you that they've unlocked the secret of post-finasteride syndrome, and you pay them a few grand and you get on their post-finasteride protocol and they will cure you, because the best minds in the world can't even agree on what this is, and they can't even agree on what causes it, let alone on how to treat it. So I have my own ideas about how we can treat something like this. I'll save those for another time, but if you want to read more on this, there's a fair amount of literature on it. This is one here, Post-Finasteride Syndrome, a Surmountable Challenge for Clinicians. This is by Dr. Traish, PhD, Department of Urology, Boston School of Medicine. This is in their journal Fertility and Sterility, so 2019, so you can do a Google search on that. Yeah, and he does a good job of like just kind of running down like what are they're not formally agreed upon, symptoms and criteria for diagnosis, but this is what the majority of patients complain of. So this is a little diagram from that paper. So erectile dysfunction, loss of libido, ejaculatory dysfunction, suicidal ideation. So there's a lot of mental health issues that come with this, with insomnia, so panic attacks, anxiety, depression. You can read it there as well as I do. So, if there were official diagnostic criteria in the future, they would probably include, these particular symptoms, because these are the ones that seem to pop up over and over again. So so no formal criteria. So if you think you have post-finasteride syndrome, I recommend you see a competent urologist or andrologist or board certified endocrinologist. And, again, just keep in mind there's controversy there, and this is a very niche condition. So even those experts might not be well versed in it. And so if you're not getting the answers that you want to your questions, or they're not answering your questions to your satisfaction, you might need to honestly shop around a little bit and find somebody who will listen to you and at least try to answer your questions. So it's a tough condition. All right, next one. If I would take HCG by itself, no TRT, okay, kind of talked about this before, I don't recommend that. Would I still see significant improvement on my test levels? It depends on what you mean by significant. So statistically significant, yes. Clinically significant, it kind of depends. So what it depends on is primarily how functional your testicles are, right? So typically, especially if you're a young person, right, you will get a more robust response to HCG because the factory is working, presumably, and you're just basically giving a LH signal. If you're older, meaning over the age of 50, you still get a response, but you're not going to get a robust response like you did when you were 25 years old. And the data is pretty clear on that. So, yeah. So like just anecdotally, I have seen guys in their early 20s get way up, like right to the top of the reference range and slightly beyond with HCG alone. And I have seen elderly men make almost no change in their serum testosterone levels with generous amounts of HCG, because like the end organ is diseased, right? And it's aged, and like nothing works as well when you're 60 as compared to when you were 20. So that's just the way it is. Now, these days, like things are different. Like just because you're young is no guarantee that you're even going to respond to HCG, right? Because again, you come into this world, especially this younger generation, already exposed to endocrine disrupting compounds. If you have got a scrotum full of microplastics by the time you're age 25, I would not expect your testicles to be as responsive to HCG or to LH for that matter as it would be if, maybe you were born 20, 30, 40, 50 years ago. So I think that's a reasonable thing to say. So it's hit or miss. Again, I don't recommend using HCG as your sole HRT protocol. There may be instances out there where you may want to do that, and I'll leave it up to you and your doctor. That's not for me to tell you what to do, but I have rarely seen that be a long-term solution. I have seen guys feel better in the short run, but it's not a long-term fix. And almost all of those guys, in fact, I can't think of any that stayed on that for more than a year before transitioning to testosterone replacement therapy. It just doesn't work. At least doesn't work long-term. But if it's for fertility, like, if it's part of if you're using HCG, not as your long-term HRT solution, but to achieve a specific goal. So are you trying to get fertile, right? You and your wife trying to have a baby. Yeah. Okay, fine. Like if you want to use HCG in that context, and then once your gal's pregnant and you're far enough along, you feel comfortable coming off of it. Okay, that's totally different. That's a different use case than just for like, I'm just going to be on HCG for the next 25 years as my treatment for low testosterone. I don't think that's a good option personally. I would not recommend that. Oh yeah, this is a good one here. Cardiac stuff. I like cardiac stuff. At this point, I've had a CAC, coronary artery calcium scan, a CINT, which is an ultrasound of the carotid arteries, and a CTA. There were all 0 scores at age 50. Okay, that's awesome, man. Good for you. Good for you. So I'm assuming what that means is that there's no calcified plaque, and there's no evidence at all, 0, of any soft plaque in your coronaries or in your carotids. That's honestly kind of surprising for a 50-year-old male, but cool. Like that's amazing. So that bodes very well for you in the long run. So his question is, does a cardiac MRI offer any further utility over these tests? My LDL is okay. I don't know what okay means, but my Lp(a) is genetically high. Okay. Join the club. So I have had an okay LDL my entire life, under 100. My Lp(a) genetically high as well. And sure enough, I did develop coronary artery disease detected on a CAC. So my CAC score was not 0 when I took it at age 50. It was 0 when I was 40, but at 50, it was not. So there's 0 CVD in my family. Okay, bodes well. All my grandparents and great-grandparents lived to their 90s without heart issues. So hopefully I'm good. Yeah, I hope you're good as well. What you're really asking with this question is, can any of these 3 studies that I've had, can they miss atherosclerotic plaque? I think that that's probably the root of the question that you're asking. Like, am I really good? Do I really have no coronary artery disease, right? So we know for sure with a CAC, yeah, you can have horrible soft plaque. And if the plaque is not calcified, it's very low utility. CIMT is really good at looking at soft plaque. But again, we're not looking at the coronaries, we're looking at the carotids. You can infer that if you have carotid plaque, you certainly have cardiac plaque. That tracks pretty well. But let's say, can you have a totally clean coronary CTA and still have some atherosclerotic plaque? Yeah, and the answer is yes. So, and there's a number of papers out there on that. This is one from Scientific Reports. Accuracy and limitation of plaque detection by coronary CTA, section-to-section comparison with optical coherence tomography. All right. When was this done? Yeah, 2023. So it's pretty recent. So there's a few instances, and it's debatable, like what do we do with this information? But if you have very small amounts of plaque, like less than a millimeter, depending on the quality of the scan, depending on how they slice the segments, yeah, you can miss like one of these small little plaque areas. And the question becomes, okay, well, is that even clinically relevant? I don't really know the answer to that, but technically, yeah, you can miss plaque. And again, it depends on the quality of the software that you're using. It's very important when you get a CTA that your heart rate is relatively low. So they like to get your heart rate like 60 or less, because if your heart is beating very quickly, it blurs the image. It makes it a little tougher to interpret that. So sometimes they'll give you oral beta blockers to slow your heart rate down before you go into the scanner. So there's a number of technical aspects to this that can limit the resolution and limit the accuracy of the test. So the way that the plaque is formed, so if it doesn't significantly encroach in on the lumen, so if it does something called positive remodeling, right, where it kind of bows outward, and it the lumen itself, when the dye goes through, it can look patent, but you can still have plaque in there, and yeah, you can potentially miss that. But it's a pretty good test, right? It's a pretty good test. And if you have a coronary CTA and it shows 0 plaque, your chances of having an MI are very low. They're like less than 2% over the next, I believe it's over the following 10 years. So anyway, having said that, so does getting a cardiac MRI in your setting with, let's just say, whistle clean, good CAC, CIMT, and CTA, is there any utility in you getting a cardiac MRI? My thoughts on this is no. I would defer to the cardiology experts. I don't order cardiac MRIs. That's my ceiling. Like, if I think you need a cardiac MRI, which, by the way, cardiac MRIs, they've got a few really, they get used for a number of different reasons. And this is probably not an exhaustive list. Again, I refer to my cardiology colleagues on this one. But if someone has a cardiomyopathy, like, you want to get a good idea of like the structure of their heart. So if you want to differentiate what kind of cardiomyopathy that they have, like what is the etiology of this cardiomyopathy? Is it ischemic? Is it infiltrative, right? Do they have sarcoid or amyloid, proteins infiltrating their heart? Do they have hemochromatosis? We want to see, like, do we have, iron overload within the heart? It's really good for that. Someone has like severe myopericarditis from viral or other etiologies, so like inflammatory conditions like within the heart muscle, that shows up pretty well in a cardiac MRI. And then people with congenital heart disease will get these. So if you're born with various holes in your heart where blood is flowing into places and in directions that it shouldn't go, it's really good at looking at like the structure of the myocardium and the structure of the valves. So it's really good for that. My understanding is you can use this as a way to screen for coronary artery disease, but like, why would you? Why would you in your case? Like, you've had 3 very good studies, the CTA probably being the best, but CINT is pretty good too, that, if what you're saying is accurate, show you do not have any detectable coronary artery disease. Like, there's no utility in you getting a cardiac MRI. So if there's any cardiologists out there listening to this and you have a different perspective, or you can think of a reason why this guy could get a cardiac MRI, yeah, leave it in the comments because you can educate me on that. But if you have one of these conditions where, you might benefit from a cardiac MRI, I mean, usually I've referred you to a cardiologist a long time ago because, like I said before, I do try to stay in my lane. This is pretty advanced stuff. This is why you go to a 3-year cardiology fellowship, right? Is so that you can order cardiac MRIs, interpret them, and decide what to do. So my answer as a lowly knuckle dragging emergency room doctor / family medicine physician is I don't think you need a cardiac MRI. But you know what? If you want it and you're paying for it, I support you, man. You go ahead. Okay, switching gears here. This is coming from one of my older videos about red flags with TRT clinics. So another flag is when your TRT provider advises you not to inform your primary care doc and cardiologist. Yeah. Right. Like, I get this. Yes, technically, right. You should always be fully transparent with any physician that you're seeing, anybody who's giving you medical care. Like, give them all the information that they need. But I get it. Like, all of us, this has happened to me multiple times. You don't want to mention that you're on TRT because immediately there's going to be some eye rolling, or there can be. The danger in this, actually, there's actually a potential downside to revealing this, in that whatever problem you're there for, and again, I've seen this multiple times in other physicians, is that whatever you're there for, whatever problem you have, as soon as you reveal that you're on testosterone therapy, it's the testosterone, right? So, whatever it is that you're there for, they'll somehow like anchor on that. And I've seen that happen, and they're not going to do, a further workup. That doesn't always, if they're a good physician, right, they're going to continue the workup, and, they may internally blame the testosterone, even though it has nothing to do with whatever problem that you have. There's diagnostic anchoring, they call it. And it's very harmful. It's lazy on their part, but it happens all the time. So I don't recommend that you withhold information from your doctor officially, but I totally get why guys do it. Okay. I get it because, you don't want to have that conversation. Quite frankly, you don't want to have that conversation with somebody who possibly knows less about testosterone than you do as a layperson. Okay. And that's entirely possible. Most physicians know absolutely nothing about testosterone replacement therapy in men, and they equate it with using anabolic steroids. And it's, it's tiresome. It's totally tiresome. I get it, man. I understand why guys do this. All right. Next one. This is a little bit out of my wheelhouse, but maybe some of you guys out there know more about this than I do. It's just about Trenbolone. Trenbolone is a Nandrolone. I know people won't be discussing therapeutic dose with Tren. There's no therapeutic dose of Tren, my friend. But would it have similar pain alleviation effects? I'm hitting 2 weeks of 100 milligrams of Tren E, and all my aches and pains are much, much less after about 10 days. I used NPP at 100 to 150 milligrams per week last year and don't think it worked as well. Anyone know about Trenbolone helping joint pain arthritis? I have no idea. This is not my wheelhouse at all. This is something like Vigorous Steve, if you're listening, you might know the answer to this. There's a few other guys out there who know a lot more about this sort of stuff than I do. There is a like I don't know, is Trenbolone considered a Nandrolone? It's a 19-nor, right? It's a 19-nor testosterone. This is the chemical structure here, by the way. This is one here with the tail. This is Nandrolone decanoate. It's got the decanoate ester on it. And then this is Trenbolone below that. It looks really similar, right? But if you look closely, right, at the C9 and C11-12, there are these double bonds. So it looks like the chemical structure is very, very similar. So I don't know. What do you guys think? The only thing like medically that I've seen the Trenbolone does, or the primary thing, is some of the worst lipid panels I've ever seen. And bodybuilders come when they're on trend. So I encourage you to steer away from this. I understand why guys like to use it, but I don't know how to answer your question. This is outside of my area of expertise. Okay, let me sit up here because this is a great question. Whoever sent this in, thank you for doing this, because I did want to talk about this. And I'm actually, like, whenever I get some spare time, I actually wanted to dedicate an entire video to this question. So I'm going to do my best. I'm going to give you like a Cliff Notes version of what I will one day eventually talk about in exquisite detail. But this is a question that came from the panel discussion that I had where we critiqued a video from a cardiologist, MedLife, I think is his name. And you can watch the video. I play his video, and then we have a roundtable discussion about it with some excellent physician colleagues of mine. And basically he was saying, like, you know, he's an interventional cardiologist, right? So he was on a stretch of shifts over a couple of weeks in England, and he saw what he considered to be an excessive number of men coming in with heart attacks who happened to also be taking testosterone. So he was raising the question, like, could this be, you know, is testosterone taken at supraphysiologic doses, or doses, what he said, high end of normal or normal for a 20-year-old. If let's say you're a 40 or 50-year-old and you're taking testosterone that gets your levels up at the top of the reference range where a super healthy 20-year-old will be, like, is that going to cause coronary artery disease? Or, you know, are guys who are taking, quote, like sport TRT, so they're taking their serum levels and they're taking them into the supraphysiologic range, not bodybuilder, like a gram of testosterone a week, but let's say, you know, we're talking about guys with serum testosterone levels above 1200, so 1500, 1600, 1700, you know, whatever the case may be, for them to alleviate their symptoms and, you know, make them feel and function at their best. So that's above the established reference range. Could that be a problem? So let me read his question here real quick, and then I'll give you my answer to the best of my ability with this. So I appreciate the reaction video, but it didn't address the key point I was hoping to get addressed. Okay. I know it didn't. I know it. We talked about it, but we didn't show you the studies. I'm going to show you a few of the studies here. MedLife says he's fine with people who have true hypogonadism being taken to normal levels. Okay. But it sounds like his patients went from normal levels to above normal levels. They might have. In his video, he actually says he doesn't know what their levels were. He didn't know because he didn't have access. They're on a different medical system. He didn't have access to their MI labs, and he didn't check testosterone levels on it. So he was assuming they were super physiologic. But let's assume that he was correct. And these guys were, I don't know, running somewhere between, let's just say 1,500 to 2,000 nanograms per deciliter. So, you know, definitely above like any normal reference range. But what do the studies say about men on TRT with levels above 900 or 1,000? What is the evidence for heart safety for someone 1,200 to 1,300? Okay, great. I'm going to do my best to answer that question. This is a great question. Even in your video, one of the docs is okay with levels up to 2,000! Exclamation point. Oh my God. I'm clutching my pearls. But the main study for heart health I've seen is called Traverse. Yeah, this is the big study, Traverse, that, you know, made a lot of news. It's a good study, has some flaws. Was using gel, and the men had temporary daily peaks in the mid to normal range. What is the scientific evidence for heart safety at these constant above normal levels? Great question. Very few men in their 20s have T levels near 900. So today, that's true. Yeah, for sure. Yeah, I mean, I know because I've seen them near 900. There, in decades past, however, this was relatively common, right? So this shows here just what's happened, at least at LabCorp, but it's happened at other labs as well, as like pre 2017. So healthy adult males, so over the age of 18, like LabCorp, normal used to be 348 to 1197. So let's just say, 350 to 1200. That for a very, very, very long time, that was the normal. So those are, if you were at 1100, then you were normal. In fact, you were probably, people were like, wow, this guy is super healthy. Like this is great. Now this is dangerous, right? Because the reference range now is, as you see here, after 2017, 264 to 916. So this is LabCorp, and then this is Quest. These are my old labs. I've searched and searched. I knew I had these on a hard drive somewhere. So you see, this is me. This is back in my military days. This is male 37. So you can. I am not 37, not even close anymore. So this was me, and this was sent to Quest in Tampa because I was stationed in Florida at the time. So you can see the normal reference range here at Quest was 250 to 1100. So that has gone down as well. And you can see my numbers here, especially my free T, 28.9 or 2.89, depending on what what units you want to use. Yeah, these were dark days. I was not feeling good these days. But just to shoot, my point of showing you this is like, so the reference range has changed, right? And nobody was raising red flags or questioning, healthy young men walking around with total testosterone levels of 1,000, 1,100, or even 1,200. They just happened to be at the top of the normal reference range. Okay, so let's dive into this a little bit because it's a really good question. Now, here's the thing: like, if what you want is a study at the level of the quality and size and rigor of the Traverse study, where we looked at men who do have these, let's just say, super physiologic testosterone levels. So if that's what you need, I'm sorry, man. Like, we're never going to get that. I wish that we would get that. I really do. It's just not going to happen, right? Like there's just, and especially at this point, now that we know that the Traverse style trial has shown that there really is no adverse cardiac risk at these lower levels. Industry is not going to sponsor a study if there's even a remote risk that it's going to show a danger at higher levels. So we're just never going to get that study. So what can we do? What can we do to try to sort this out? By the way, the Traverse trial, if I'm not mistaken, they eliminated you from the study if your levels got above 750 twice. So if you had a level above 750 or above on gel, which was a sizable number of guys, they lowered your dose. And if at any point you tested above 750 again, they yanked you out of the study, which I think was a huge shame because I would have loved if they've left those guys in there or like put them in another group and just let them ride, because maybe then we would have a better answer to this question. And, we'd see guys, if they're walking around 800 or 900 or even 1,000, there's a few of them, my feeling is that we would not have seen any increase in adverse cardiac events, but we'll never know because they pulled those guys out of the study. Again, it's an industry sponsored study. They wanted this to look clean. They wanted it to look good. They didn't want to take any chances. And so those guys were out, unfortunately. So, okay. So what can we do in the meantime? Like those of us who prescribe TRT have been doing it for quite a long time. If you have any experience in this field, you will realize that there are guys out there that do not begin to feel better, whose metabolic markers, whose other health parameters do not start to improve until the dose is pushed up towards the top and often beyond the reference range. Okay, that is a clinical phenomenon, and that is why, following numbers and making dosage and protocol adjustments solely based off numbers without any kind of clinical context is probably not the best way to do TRT. So let's look at this maybe like from a 10,000 foot view. So, we I won't say we have all the answers with atherosclerosis, but especially over like the last 10 to 20 years, I mean, we've got the main parts of this, we've got it figured out, right? So there are some like really well established risk factors where we can pretty much predict based on these risk factors, like what your probability is of getting cardiovascular disease in at some point in the future, right? They're not perfect. There's plenty of people out there that have none of these and still end up with, occluded coronaries. They still end up having strokes and DVTs and all that kind of stuff. But these conditions tend to track pretty well with these risk factors. Okay, so these are not in any particular order, but like if you have a high number of ApoB containing particles, right? Like ApoB, don't shoot the messenger, is causal for atherosclerosis, right? If you have no ApoB, you do not build atherosclerotic plaque. You can have other problems, but it's ApoB is what causes atherosclerosis. Okay, there's all these other things that contribute. They're accelerants. Okay, they're gasoline on the fire. Okay, but you got to have ApoB. So high ApoB burden. Cigarette smoking, like duh, everybody knows this, right? It greatly accelerates atherosclerosis. Diabetes and insulin resistance, hypertension, right? We know hypertension can accelerate cardiovascular disease, chronic inflammation, right? This is a big one. And, that's why we measure HSCRPs. And, some people like to go even deeper and get, interleukin levels and stuff like that. I don't particularly think that's necessary, but you can do it if you want to. But the HSCRP, like, it does correlate. There's an association there for sure with increased risk, especially when other risk factors are under control. If you have high inflammatory markers, the risk seems to go up. Okay. Lipoprotein A, I've talked about that as well. Super atherogenic, also ApoB containing particle, right? So high levels of LP little a, even in the absence of other risk factors, does increase your risk of getting coronary artery disease and strokes, DVT as well. So, and then the central like root cause of most of these actually, other than like lipoprotein A and cigarette smoking, is obesity. Like visceral body fat is directly related to levels of chronic inflammation, right? Hypertension, there's definitely a component of inflammation from visceral adiposity that directly contributes to hypertension. It's one of the mechanisms by which you can lower your blood pressure is by losing visceral body fat, right? And there are a number of different reasons for that. So, and then of course, it goes without saying, like diabetes and insulin resistance, again, directly related to your levels of visceral body fat and these, harmful adipokines that are secreted by visceral body fat. So, those are the big ones. There are other risk factors for heart disease. And quite frankly, there's a lot of unknown genetic and gene contributions to this that we're just uncovering, right? So it's not an exhaustive list, but these are the big ones. And these are the ones that are like, they're very easy to track. Even as a primary care physician, you can, I track all of these in my guys. And so I want these in the optimal range. And so having said that, now we can proceed and maybe we can make some conclusions, some tentative conclusions about the dangers of these, slightly superphysiologic testosterone levels. So what does the data show? Believe it or not, there's not many, right? And they're not at the level of the Traverse trial, but there are a number of studies out there where they have given very high doses of testosterone to both young and old men. And, they've seen what happens. So this is one, and most of these are kind of old. This one's from 2013, Translational Physiology, Effects of Varying Doses of Testosterone on Atherogenic Markers in Healthy Younger and Older Men. Okay, so again, not like the Traverse where they had guys who already had pre-existing disease and other medical conditions. These guys were relatively healthy to start with, as are most guys that start TRT. That I take care of a lot of guys that have, more serious chronic medical issues, but the average guy that comes into a TRT clinic is not going to have a ton of these, other medical issues. So this is an interesting study. And they gave like varying doses of testosterone to these guys. Low dose, they gave like 25 milligrams a week, 50, 125. And then they went up to 300 milligrams a week and 600 milligrams a week. I think it was enanthate that they give. Yeah, it was enanthate. So I'm going to cut out all the ones less than 300. So, when I talk about this study and some of the subsequent ones, I'm talking about the guys that were given 300 milligrams or 600 milligrams of testosterone per week. clearly an excessive dose, clearly above anything that could even remotely be considered TRT. Like you're solidly juicing. It's definitely at like 600 milligrams. So what they did in this particular study, this one they were looking at the inflammatory markers because, again, like I said, inflammation is a component of atherosclerosis and cardiovascular disease. And they measured quite a few. Okay. Like I primarily look at the HSCRP, but there's a lot of other ones out there. They looked at MCP1 and SICAM1, this 8-iso-PGF2 alpha, which is a measure of like oxidative stress. And they did this over 20 weeks. So they looked at a whole bunch of markers related to inflammation and oxidative stress, they correlate with increased risk of atherosclerosis. So what did they find in these guys, both the young and the old guys who were taking huge amounts of testosterone? And it says here, the primary conclusion, across this wide dosage range, testosterone did not worsen these atherogenic biomarkers. So there was no statistical significance between the placebo, the low dose, or like more reasonable like TRT doses of testosterone, and these clearly like super physiologic doses. HSCRP didn't change significantly, and neither did any of these other inflammatory markers. By the way, they also, at every follow-up visit with these guys, they collected additional data, including blood pressure values. And it says right here, no statistically significant increase in systolic or diastolic blood pressure in these groups. No dose-response relationship for blood pressure. And it said even at 600 milligrams a week, mean blood pressure remained within the normal range. So, okay. So that's interesting, right? I get it. It's one study. It's 20 weeks. It's in guys who are previously healthy. But this is a useful data point to me. Okay. So when it comes to two of the major risk factors, which is inflammation and blood pressure, at least in this study, we're not making these guys worse, right? They didn't get better. They didn't get better, but we didn't make them worse, even at 300 and 600 milligrams. Okay. Again, take it for what it's worth. It's, it's not a massive study. So, what do they have? They had 121 guys in this study. So, all right. So moving on. Okay. So what about lipids? So here's another study, kind of a similar type of study. So this one is effects of varying doses of T on insulin sensitivity, right? So again, diabetes, prediabetes, insulin resistance, we know that this contributes to atherosclerosis. Plasma lipids, so ApoB, LDL, we talk major driving force, right? Causal in atherosclerosis. Apolipoproteins and C-reactive proteins. So this one, they looked at lipids and they also, so we have not yet another data point looking at an inflammatory marker that, is commonly associated with atherosclerosis. So same protocol, 25 milligrams, 50, 125, 300, and 600 milligrams a week. This was all in young guys. How many guys were in this study? So they had 61 guys, and they were between the ages of 18 and 35. All right, so they didn't have the old guys in this study. So what did they find in terms of cholesterol? So HDL, it did go down a little bit. And again, I'm only referring to the big doses, right? 300 and 600. So at 300, HDL-C went down an average of 8 to 10 milligrams per deciliter. That was considered statistically significant. At 600 milligrams, you got a dose-related decrease or increase in the decrease. HDL-C went down 15 to 20 points at the mega dose. And, you do see that in clinical practice. Some guys do get a little dip. Most of the guys on my panel, their HDL doesn't really change that much. And, quite frankly, with some of the newer data showing that like worrying and obsessing over HDL levels, trying to artificially raise HDL levels when they're low, it does not really impact the natural history of the disease. So I don't worry that much about HDL anymore. I mean, we were trained to worry about it 20 years ago, but it's just not it's not the issue that we used to think it was. ApoB is probably a much more important thing to take a look at. So, or LDL. So let's look at both of those. So, okay, so that's HDL. So LDL at 300 milligrams a week, there was no change. So the mean LDL, it actually stayed the same. So no statistically significant increase, at least in LDL. So it didn't get better in this case, but it also didn't get worse. And then at 600 milligrams, there was a small increase in LDL. Okay, like they said, 5 to 10 milligrams per deciliter. Okay, that's, so whatever. Like take that for what it is. 600 milligrams a week. Nobody's doing TRT at 600 milligrams a week. In MedLife's videos, like he didn't specify how much testosterone these guys were taking. So he didn't know the levels, he didn't know the dose. And then as we talked about in the video, he didn't know, or at least he didn't mention whether they were on any ancillaries. Were they taking non-aromatizable synthetic androgens? Were they taking aromatase inhibitors, which in my opinion probably had, if they were, had more to do with their plaque rupture than their whatever their dose of testosterone therapy was. So that's LDL. ApoB, again, you would expect, it'd be also unchanged, and that's exactly what they saw. So 300 milligrams a week, no significant change. And then actually, for at least in terms of ApoB, at 600 milligrams, there was no change. And by the way, with triglycerides, also no change in either of these two doses, 300 or 600. So yeah, like big doses of testosterone, again, way more than you would ever see with any reasonable TRT protocol. And we're not of these major cardiac risk factors, chronic inflammation and dyslipidemia and blood pressure. So far, we're not seeing it get worse. It doesn't sound like it's getting any better in these guys over 20 weeks. Now, if these guys stayed on this dose for longer periods of time, maybe we would see some beneficial changes. I suspect that we might as body composition changes. However, over the course of 20 weeks in these small groups, we're certainly not seeing any indication that like their risk profile is like dramatically getting worse, even at 600 milligrams a week, right? Which is like totally excessive, right, when it comes to TRT, but not uncommon in the bodybuilding world. In fact, 600 a week is kind of on the light side from what I've seen. Okay, so let's move on. Let's do another one here. This one, American Journal of Physiology and Endocrinology Metabolism, 2001. So these are, older studies. Nobody's interested in doing these studies these days. Testosterone dose response relationships in healthy young men. Again, another 20-week study, same protocol, where they gave exactly the same like doses, like I said, 25, 50, 125, 300, and 600 of enanthate per week, and they looked to see what happened. So this is regarding insulin sensitivity and visceral body fat composition. So another like two major contributors to cardiovascular disease. So what did they find? I mean, this shouldn't shock anybody, right? Like higher doses of testosterone, you get a dose-dependent reduction in fat mass. And as we've shown in other studies I'm not going to talk about, there's a dose-dependent increase in lean mass and strength, muscle hypertrophy, et cetera. That's what testosterone does. So again, what did they find here? So dose-dependent reductions in fat mass. At higher doses, so above the 300 and 600, they saw insulin sensitivity improve. And this was, it said, driven by the loss of visceral body fat. So guys, dropping visceral body fat is the key. I truly believe like it's one of the fundamental pillars of longevity is you cannot have excessive amounts of visceral body fat. You really need to, once you do that, many of these other problems just like take care of themselves. So you got to get lean, So it said no worsening of fasting glucose despite extreme androgen exposure. Okay. Which it shouldn't be too surprising, right? I mean, you're losing visceral body fat, you're gaining lean muscle tissue, so you're improving insulin sensitivity. You wouldn't expect there to be dysglycemia, right? You wouldn't expect glucose levels to go up when testosterone exposure goes up. It would be the other way around. So they conclude here that says this study shows that very high testosterone does not impair and may improve insulin sensitivity even when far above the physiologic range. Yeah, that's true. So that's true. And honestly, I mean, that's what I see in clinical practice. Like not all of my guys, have levels outside the reference range, but some of them do. And that combined with the training and diet regimen that I recommend for them, amazing. I mean, the results are amazing. The visceral body fat just melts away. They start gaining lean muscle tissue. And when I check their labs, their hemoglobin A1Cs, they tend to just drop. Their triglycerides come down. Their lipid panels improve. If they had elevated CRPs, they also tend to come down, And so it's a combination of things, right? The testosterone is doing what it does, but they're putting in the work. They're losing the visceral body fat. They're changing their diet. They're getting regular resistance exercise. And so, that combination has amazing, amazing health benefits. And so it's a hard sell to me that when I have a guy who comes to me at 300 pounds and a year later is down to 230 pounds, and we put him in the DEXA, and he's lost 60 pounds of visceral body fat and, gained 10 plus pounds of lean mass. His lipids are perfect. His blood pressure is perfect. But his serum testosterone level is 1700, let's say. That's a hard sell if you're going to tell me that I've increased this man's risk of dying from cardiovascular disease. Like, I'm going to call bullshit on that. Bullshit. I don't care what that level is. Look at all of these other secondary markers. Like, they're so much better. What's happened actually is this man, through his hard work and with the help of testosterone, has dramatically, in my opinion, reduced his chance of having an adverse cardiac event in the next 10 years, despite having this, quote, out of reference range testosterone. So it just doesn't make any sense. Okay. And then, we'll kind of finish up here with, this is just one more. I want to show you these because, we always say, yeah, these studies exist, but like, why don't I need to show them to you, right? So you can actually Google these, look at them yourself, come to your own conclusions. But I'm not making it up when I say that, that we do have studies with supraphysiologic testosterone. And this is just one more. This is the Journal of Clinical Endocrinology and Metabolism, 2005. Older men are as responsive as young men to the anabolic effects of graded doses of testosterone on the skeletal muscle. Okay. This is a good one because it shows, like, even old farts, they respond quite nicely to testosterone, and they respond quite nicely even to very high levels of testosterone without, at least, again, over 20 weeks, we're not seeing major side effects. We're not having a huge amount of guys dropping out of the study. So this is 60 men healthy between 60 and 75 years of age. Okay. So no obvious major comorbidities, but these guys were old, right? 60 to 75, you're elderly, in my opinion. And apologize to you guys in that age group if I've insulted you, but to me, you're elderly. All right. So again, same protocol, right? So we'll look at just the high dose ones, right? 300 milligrams and 600 milligrams. How much fat-free mass did they gain? This is on a DEXA. So over 20 weeks, so the group in the 300 milligram group, they gained 5.6 kilos of fat-free mass. 600 milligrams, not surprisingly, 7.3 kilos. What's interesting, though, is like there's a point of diminishing returns, right? So the 125 milligram group, they gained 4.2 kilos. 300 milligrams gained 5.6, and then the 600 milligram group gained 7.3. So, like, do you really need 600 milligrams? Maybe we can get by with 125, 300. That's a sweet spot. We can avoid some of the side effects because some of these men in this elderly group, they did develop some leg edema, right? And there were a small number of them that dropped out of the study because they had peripheral edema at 600 milligrams, which, dude, that's going to happen, right? That's going to happen. So what did they see here with these guys? So they gained a lot of lean mass, which is great. Okay. Especially important. This is super important in this 60 to 75-year-old range. And you could even say that this may be a reason to push the dose in especially a frail elderly man who is at risk of falls. This is an opportunity to put a little bit of extra muscle tissue on this guy. It literally could save his life. So, on a case-by-case basis, maybe there is an indication in older men with proper supervision to use these higher doses. Okay. I don't have anybody in this range, in this age range currently that I have big doses like that. My protocols are actually pretty conservative, but anyway, these guys, some of them did have some leg edema. In terms of their lipids, they had the expected drop in their HDL, LDL, and triglycerides. They were static, right? No change, just like we saw in there. And the blood pressure in these guys, elderly men, and the young guys, we saw no change in blood pressure. Guess what? In the older guys, I find this somewhat reassuring. I get it's a small study. In these elderly men, taking 600 milligrams of testosterone a week, they did not see a statistically significant change in their blood pressure, either up or down. Okay, so it was static. So that's That's my answer to your question. Sorry if it's a bit lengthy. So, does this say, does this information, does this tell me that, serum testosterone levels of 1700 in otherwise healthy men over 20 or 30 years is perfectly safe? No, it doesn't tell me that. Like, we're never going to have that study. But right now, this is the best that we can do. We can look at all of the cardiac risk factors that we know of, non-genetic cardiac risk factors. We can look and we can track those in these men who are taking testosterone in levels that pushes them outside of the upper limits of the reference range. And universally what we see is, one, they don't seem to get worse, and in many cases they get better. So that's why, in that reaction video, that's why we were pushing back on some of MedLife's statements, because again, we're never going to get a study as good as Traverse that, in taking, you're never going to get a Traverse style study on guys taking 300 or 600 milligrams of testosterone. Like, no IRB would ever allow that to happen. It's just not going to happen. But using the available data that we have and closely monitoring our patients, those of us that have been prescribing TRT for a long time, and we're not seeing any of the stuff that he talked about in that video. So I think his video is alarmist. I don't want to be too hard on him. Testosterone is not his area of expertise. He's a cardiologist. I've no doubt that he's an outstanding cardiologist, but I thought that video was a little clickbaity and borderline irresponsible, but that's it. Otherwise, I don't want to be too hard on him. I actually enjoy his channel. It's totally good. You guys should check it out. So that's my long-winded answer to your question. Okay. We'll talk about this some more on this channel, because I'm interested in this kind of stuff. I treat a lot of cardiovascular disease at the end stages of it, and I have a vested interest in helping not just myself, my family members, but you guys as well, not end up in my emergency department as a cardiovascular patient. So, okay, moving on. I needed thoughts on 10 milligrams every 2 days. This is about Tadalafil or Cialis. Like, the typical dose is, like, for low dose is 5 milligrams every single day. He's like, thoughts on, I don't really have thoughts on that. I don't know. You can do that if you want. It has a long half-life. It would probably be effective, but, like, don't get cute with it. If I have to take something, if I have a choice of taking something once a day, or I have a choice of taking it every other day, or some other, like, non-consecutive pattern, like, my compliance is going to go down. I'll wake up, tired. I'm been, like I did this morning after my shift, and be like, oh shit, did I take it yesterday? Did I not take it? For me, like, I just want to take something. If I take it every single day, I'm going to be compliant with it. So I prescribe it as once a day. You do what you want. If you feel like it works better for you every 2 days, too, right, go for it. Go for it. I don't have strong feelings one way or the other. Okay. All right. This one, I'm on 1 cc of Testosterone 250 per week. Okay. You're probably not in the United States. Self-medicated. All right. First red flag. I've been getting large nipples. Been taking E-Break by Magnum. I had to look that up because I didn't know what E-Break is. Excuse me, but feels like it's shutting me down. I don't really know what that means. Feels like it's shutting you down. I don't know. I don't want to get out of bed in the morning. Okay, so you're fatigued. You know what? I didn't want to get out of bed in the morning today either. And I am about as optimized as you can possibly be. I felt like complete dog shit this morning. Are you saying not to bother with DIM? Yes, I've always said that DIM is a complete waste of time. Anybody that prescribes it and tells you it does this and does that is probably, at best, ill-informed. At worst, they're scammers. I don't want to get man boobs. Okay. I don't want you to get man boobs either. LOL. I'm not looking to grow a pair of boobs. Okay. All right. No, thanks for saying that, because, some guys are looking to grow a pair of boobs these days. Yeah, DIM is a complete waste of time. I have a full video on that, guys. You can watch it, and I'll explain to you, my reasoning behind that. It's just stupid. The best way to get, if you want DIM in your life, is to eat a lot of leafy green vegetables that have DIM in it. That's a great way to get DIM. Get all the health benefits of those vegetables, and for a lot less cost than popping DIM pills. Okay. It's a waste. So what is e-brake? So I had to look this up. This is a picture of it. This is another scam. This is another like little bit of snake oil. This preys on guys' fear of estradiol. And so these are the ingredients here. You can read them just as well as I can. If you don't believe me, do a quick Google search or a AI GPT search on these. They don't do anything. They don't do a damn thing. They're little to no effect on estrogen levels, estradiol in humans. The data is completely poor. You're being scammed. Anybody that takes this stuff, you're just wasting your money. You're flushing your money down the drain. This is like total horseshit. Supplements like this, like I know that the guys that make this stuff know that this is crap. Like they're not stupid, right? But these guys are. This is like predatory marketing. They're playing on the fears that, like you, a guy who is self-medicating with testosterone, presumably from an underground lab. So you have no idea what you're actually taking. You don't have any physician supervision. You have no idea what you're doing, most likely. And, you've got these fears, probably unreasonable, of gyno. And so you're just like going on a forum and somebody is recommending this crap for you. And, there's this supplement company, Magnum Nutraceuticals, I think. They're more than happy to put together this crap supplement, sell it to. I don't know how much it costs. It's probably $30 to $50 a month you're paying for this garbage. What does it say? Is it 72 tablets in here, and you take 3 at a time? Yeah, don't waste your time, man. Listen, first of all, go find a good doctor, right? If you're serious about TRT, you want to be healthy, you don't want to have any adverse effects, like don't just wing this on your own. Like, just talk to somebody who knows what they're doing. Don't be stupid. All right, next one here is 0.3 4 times a week at 100 milligrams per ml, a solid protocol, starting at 290 total testosterone. I mean, it's okay. I mean, what is that, 120 milligrams total per week? Yeah, I mean, a lot of guys do well on that. You're dosing it fairly regularly. So, 4 times a week dosing, there's nothing wrong with that. Most guys do very well with that if they can stick to it. Yeah, I can't say whether that's going to be a good protocol for you or not, right? Time will tell. My doctor seems strange about 200 milligrams per 1 ml versus, so that's, I don't understand why. Like, it's just math, dude. Just like, it's just a concentration difference. So I don't know. There's some weird physicians in the TRT space. They do some things and they say some things that sometimes I shake my head. But anyway, it's reasonable. Anyone who sees this and has opinions, I would appreciate it. He may not want to answer. I'm 48. Yeah, I mean, I don't know your circumstances. Okay, I haven't evaluated you. I don't know your past medical history, but I can't tell you whether this is going to be a good protocol for you or not. It sounds like a reasonable place to start. Okay. I don't see any huge red flags other than your provider being weird about the concentration of the vial that he prescribes to you. I don't know why they would have a problem with a 200 milligram per ml vial versus a 100 milligram per ml vial. I don't know. That doesn't make any sense to me. So, okay, moving on. Amazing lecture, doctor. Thank you. Your content always delivers in being both understandable and being significantly more sophisticated than most medical informative channels. Thanks. Yeah, I appreciate that. I don't know how understandable it is. I do my best. I mean, I'm kind of long-winded and I ramble a little bit, but you know what? This is what you get. It's what you get. I do like to be more detailed and maybe quote more sophisticated. I cannot stand dumbing stuff down. Okay, I can't. I'm like physically incapable of dumbing down information. I want things to be understandable, but like you don't have to dumb it down to make it understandable. You just have to do a better job at explaining it. And that's what I found over the years, like teaching interns, residents, and med students. They're all very intelligent. They've got baseline levels of information, but you're giving them information that maybe they're not familiar with. So you just have to, you refuse to dumb it down for them. But I do my best to explain it in ways that they can understand. And, I'm getting better at it. It's This is something that just takes a lot of practice. So, do you have any sources that you recommend for someone interested in learning more about the topic of hormones? Okay, great question. My God, so the internet is it's a cesspool of misinformation about testosterone. I mean, probably 90% plus of what you're going to come across if you just do random searches on forums and YouTube sites, it's going to be, it's quite frankly, it's going to be just completely wrong in many cases. So it's tough out there. Like, it's super easy to get led astray by influencers who talk a good game, right? They sound like they know what they're talking. They quote studies, and whatnot. Many of these guys, and I watch them, I actually pull up the studies that they quote. Okay, because I know how to read scientific studies, and they totally misinterpret those studies. But if you don't know that, they sound really good. He's quoting science. He's got the paper right. Blah blah blah. And I'm looking at the study, and I'm like, bro, this doesn't say anything. It's not even remotely related to what you're talking about. There's a couple of guys I'm thinking about that do this all the time, and they quote papers. They're not physicians. They're just bros, and they don't know what the fuck they're talking about. So I sympathize with you. Like, this is very, very tough. So, okay, you want specific recommendations. So if you're brand new to TRT and you don't want to be led astray, and you want to find a place where you're going to get to interact with good providers, guys who really know, they know what they're talking about. I know this because I know, many of them personally. The TRT and hormone optimization channel on YouTube. Okay, Stephen Devos runs that channel. There is a Facebook group there as well. It's probably the best one. It's not probably. It is the best one. It's a channel that's been, I don't know how long Stephen has had it. It's well over 5 years. There's a wealth of information. If you just take the time and like go through those videos, you're just not going to be led astray. I've been on other forums for different testosterone groups. I've watched some of their content, and invariably, it was so bad that I had to leave, and it was so not evidence based and just stupid that I couldn't take it anymore, so I had to leave. So I've gravitated more towards that site. I am on there. I occasionally answer questions. I'm just so busy. I wish I had more time to answer questions there, but there are a handful of really competent providers, physicians, NPs, and PAs who really know their stuff, and they can answer questions on that site. So that's honestly, if you're a layperson, and especially if you're just getting started out in TRT, that's a good place to go. Shameless plug. I put together like a introduction to TRT course with two of my physician colleague friends. And there's a link to that in the show notes. You don't have to buy it. I'm not telling you to go buy my stuff, but I think it's a pretty good course. It's if you like my style, if you like evidence, and you want a rational approach to TRT, I think you'll enjoy it. So you can check that out too. But you can find all that information on your own if you just want to dig a little bit. But yeah, the internet is a cesspool. Like, Reddit is just like, do not go to Reddit to get TRT information. Do not crowdsource medical advice in general, whether that's on Facebook, Reddit, any of these groups. There are people out there who, again, they sound very confident, and they'll give you, this is how you have to do it. And they don't have the first clue about what they're talking about. And they've given some of the worst advice I've ever seen. So it's tough. It's really hard to find out who's good. It's really hard to find out who's good. And, not surprisingly, what you see in the world and in our culture in general is that, the people that get the most press, that are the most popular, that have the biggest followers and the largest amount of like channel views and video views, they're often like the least competent, people in this space. And some of the best ones out there, and I'm not putting myself in that group, but some of the real OG experts in the hormone and TRT and like health optimization space, like, they may only have a couple hundred views on some of their videos. And these guys are like world experts, but they're not flashy. They're not sitting there in a tank top with neon signs in their mom's basement and telling you how it is. You got to do this, and your doctor's an idiot. I know better, and I know better. Those guys don't get, they don't get the views compared to the bros, the TRT biohacker bros. And so it's just the way it is. So yeah, it's hard. I'll talk later about like what I recommend for physician training, because that's a different question. If you're actually a provider and you want to learn how to do this well, it's really tough. Are some courses out there. They're unfortunately historically one of the very best ones is being dumbed down, which really bothers me a little bit. So it's actually hard to get good training in this unless you like literally mentor or like attach yourself to somebody who's, a good competent provider and can like teach you one-on-one. So this is something I'm interested in doing in the future. Once I leave emergency medicine, is like get together, either do it on my own or do it with, a small number of physician colleagues and like put together the highest quality, literally like PhD level, residency fellowship level training that you can possibly get in the subject of, hormone and health optimization. Because right now there's some that are okay, but like, I don't know, I'm unsatisfied with what's out there. So, maybe in the distant future, I'll put something like that together because I want to see this space. I want to see it grow. I want to see the number of competent providers increase. And I want to do away with the stigma that it has in the mainstream medical community, because the mainstream medical community thinks that TRT, hormone optimization, all this stuff, age, whatever you want to call it, they think it's a joke, right? They think we're clowns. We think we're steroid users at best. And at worst, they want to take our licenses away and like throw us in jail because they think we're harming people, which is totally not true. But the reason they think that is because of there's no shortage of, these clown clinics out there that are prescribing anabolic steroids and doing terrible protocols, and they're giving hormones in unsafe ways. They're not monitoring people properly, and they're getting on the internet and saying stupid stuff, and it makes us all look bad. So I would like to see that course correct. That's, somehow, and I'm not sure how we're going to get there, but as usual, it starts with education. So, all right, off my soapbox. Okay, I think we're getting close to the end here. I'm getting tired. Okay, hi. It seems that dutasteride/finasteride may block 5-alpha, mainly blocks 5. Yes, it does, but they don't block 5-beta reductase. Yeah, that's true. So it looks like 5-beta DHT can still be produced while on dutasteride. Yeah, that follows. And the reduced 5-alpha pathway might even shift more testosterone metabolism towards theoretically it does, but again, just because you put more substrate in, there are rate limiting steps within the enzyme. So generally early on, as you increase the substrate, you will increase the output from that enzyme, but then you reach the saturation point. It's called Michaelis-Menten kinetics. And then no matter how much more substrate you put in, you don't increase your output. Okay. That's why with estradiol and DHT are like good examples of that, right? So if you look at, for early on, for a given dose of testosterone, as the testosterone dose increases, the estradiol level will also increase, but then it reaches a plateau. So when, you reach a certain point, the enzyme is saturated, and adding in more testosterone, it actually doesn't result in more estradiol production. There's a limit, right? So what do you think? Is that an accurate way to think about it? Yeah, I mean, it's mechanistically, it sounds no problem with that. It sounds good. All right. Okay. I've been asked this question actually on a number of different occasions, and the answer is I don't know, and probably nobody knows. But the question is, what's the highest test dose someone can run forever without any detriments to longevity? Any biomarkers to track? Okay. Or to keep track of. So I kind of answered that in my last question. So, the main, at least for cardiovascular disease, those biomarkers I talked about when I answered that previous question about supraphysiologic levels, like those are things that you want to keep in the optimal range, regardless of whether you're on TRT or not, right? Regardless of what your levels are. If you want to live a long, healthy life and not die prematurely of cardiovascular disease, I mean, as we know right now, those are the things that you really should be focusing on. So, like, I don't know what the highest, I don't know what can you run 600 milligrams forever just because, a few old guys tolerated it really well for 24 weeks. No, I mean, I don't know. You can't say that. My feeling is like, no, you probably can't. Right. One thing MedLife said was like, there's no free lunch. And that, in that regard, he might actually be correct. So, yeah. So I don't know. Nobody's going to do that study, at least not in the United States. Maybe in North Korea, they would do it, but not here, or not in the US. Okay, there's an elusive serum T level in the 1000 to 1600 range. It's not that elusive, man. A lot of guys get that. It's pretty easy to find that level where it's slightly super physiologic. Some people call it sport TRT or TRT plus. Okay. Cortex Labs and Ryan Root, most notably. Is this safe long term? So again, the answer is I don't know. I don't know. But I'll refer you back to what I just said a little bit earlier in this video, in that in the limited amount of data we have over relatively short periods of time, there don't seem to be major adverse effects from doses up to 600 milligrams. Now, again, there's insert all the necessary caveats to that. So I don't know. I don't know if staying on 300 milligrams total a week for 30 years, starting at age 40, I don't know what that's going to do to your life expectancy. I don't know what it's going to do to your chronic disease risk, because I don't have any studies that would ever, that can even possibly address that question. Okay. What I will tell you is in this range that you're talking about, over the last many, many years, not seeing any issues in my little bubble, okay, and in my colleagues who practice this sort of medicine in their bubbles as well. So that's not science, that's not evidence, it's anecdote, but I'm just sharing you what I have seen and what I've seen in the very limited amounts of literature that are out there. So he finishes, the Traverse trial can't be extrapolated to these exotic doses. Yeah, exactly. So given that they kicked men out of the study if they got above 700, yeah, I think it was 750. But yeah, you're totally correct. You're totally correct. Traverse, this realm is not covered by the Traverse trial, not at all. So, caveat emptor, my friend. Okay, so I've heard from several doctors that they hate pellets. Yeah, I'm probably one of them. I don't hate pellets. There's very few things I hate in life. There's a few things I hate, but pellets is not really one of them. I don't think pellets are a great way to do TRT, but let's continue. I stopped at, quote, terrible. I don't think it is warranted. The excuse I always hear is that you can't adjust the dose. Well, that is true. That's true, you can't. But if they start conservatively, you won't overdo it and you can supplement with something else. Okay. I wanted pellets and they've been fantastic. Awesome. Awesome. Of all the recommendations that are out there to administer more frequently to reduce spikes, pellets are continuous. Yeah, I mean, that's true. The levels are steady as a pellet disintegrates and releases its hormone. It's a relatively smooth downward curve once you reach a peak. I've had a great time with them. Good. I am not against pinning because I pin extra T, HCG, and GnRH secretagogues. Don't do that. Glutathione, etc. None of these things were offered by my TRT provider. Good. I got them separately. Yeah. There's nothing wrong, obviously, with testing HCG, GnRH, secretagogues. No, I've got videos on that. That's stupid. It's a waste of time. But anyway, that's not, let me stay on topic. So listen, man, if pellets work for you, if you like pellets, totally fine, man. Go for it. Go for it. So, there are pros and cons to every single delivery method with testosterone, right? And so those pros and cons, you weigh that with what the patient wants and what they need. And so, the downside to pellets are, one of them is what you just mentioned, right? It can take some time to get you on the right dose. And, as those pellets break down and disintegrate, you will spend a certain period of time in what's an ideal range for you. And then towards the end of that time period, you will be at a level below what's ideal for you. And then you'll have to get another dose of pellets and you'll go back up, and then you'll spend another chunk of time in an optimal range. And then at the tail of that, you'll be in a range that maybe is not optimal for you, and you may not feel as well. So if you're okay with that, and you want fire and forget, and that's totally fine. You can do that. The other problem with pellets is, honestly, sometimes they fall out. Right? I don't talk about this a lot, but like, it's something, the rates is somewhere like around 10 or 12%. Like, they can extravasate, right? They can pop out. So it's a minor surgical procedure. You've got to have, some stitches in there for a few days. So if you're an athlete, if you do jiu-jitsu, like, you're not rolling until that wound is healed, right? You don't want it to pop open and your pellets fall out, which totally does happen. So it's up to you. Like, if you're having a great time with these pellets, who am I to tell you not to do pellets, right? You go. I don't do pellets. I have no interest in doing pellets. I think there's better ways of going about this. So, but if they work for you, my friend, like, you have my support. Okay. Are you still using the 50 milligrams of Nandrolone? Yeah, I think I've talked about this before, and I'm not. So I haven't used Nandrolone in about a year and a half. I can't access it here in the UAE. I did get a good, I got a lot of joint pain relief from Nandrolone. I think I've been open about that. I have concerns about Nandrolone long term. I don't think it's beneficial from a cardiovascular standpoint. It's definitely not a longevity drug. It has potential over years and years of use, to potentially shorten your life, based off the limited amount of data that we have. So I don't recommend Nandrolone except as a kind of a last resort for chronic pain. If I had a choice of, living the next 30 years in severe chronic pain, but then maybe risking some adverse effects, I'd have to think about that. How bad is the pain? How much is it affecting my quality of life? Chronic pain is no fun. So, I don't wag my finger or point fingers at anybody that wants to take Nandrolone. I got a great response from it. But knowing what I know about its potential long-term cardiovascular effects, I'm not, especially now I've got young kids. I have mixed feelings about it, as you can tell. I kind of struggle with it because it really helped. I have a lot of chronic pain issues that I deal with. I just had a whole body MRI, and maybe I'll share it with you guys, but it's pretty horrendous in the joint areas. So anyway, to answer your question, yeah, it's been at least a year and a half since I've taken Nandrolone, and my hips can corroborate that, and my knees. Such a great video. Thank you. You're welcome. This is the enclomiphene. I'm about to start enclome myself. Do you still have the same opinion 2 years after posting this video? Now that you have a bit more clinical experience with it, yeah, I think my opinion really hasn't changed. Enclomiphene is not a great long-term solution for TRT. Now, if you want to go ahead and try it, there are some guys that do well on it, but I don't know anybody that, well, I shouldn't say that. I know one guy who it wasn't on Clomid, he's been on Clomid, I think he's going on like 3 years, and continues to feel great on Clomid 3 years after starting with solid levels, no adverse effects. That guy is the exception to the rule in my experience. So most guys, they do, many of them feel better initially, and then they don't, right? And that's because they're blocking estradiol in the CNS, right, in the brain. You don't want to block estradiol anywhere in your body, and definitely don't want to block it in the brain. So while their testosterone levels remain high, they don't get the benefits of that elevated testosterone, because much of the benefits of testosterone, as you guys have heard me talk about, it comes from estradiol. It comes from the aromatization of estradiol and then the binding of estradiol to the estradiol receptors in various tissues. And in the brain, enclomiphene, blocks that. So yeah, so guys don't feel well on it. So when can you use enclomiphene? It certainly can be helpful in the fertility realm. Okay. If you want to just, if you have low LH and FSH, let's say you've come off of testosterone and you want to, maybe you want to regain your fertility, you need to get your LH and FSH up a little bit quicker. It can help with that as like post-cycle therapy, but it has limited uses for limited periods of time. And then in my opinion, you should probably discontinue it. It's not a great long-term solution for TRT. I mean, I don't know how else to say it. Okay, next one. So, and this is in big caps. Soy milk makes me fat and bloated. Okay, don't drink soy milk. Literature says no. My experience says it does. Okay, how do you know when? This is why I put this in there, because it's actually a good question. I don't mean to laugh. How do you know when to go against the science to make yourself healthy? Okay, I've done everything to clean up on my own for 10 years. I get a prescription and a blood test from my clinic doctor who glosses over my blood work, so I have to get a copy and adjust absolutely everything on my own. Yeah, I mean, be careful. I get it. Don't practice medicine on yourself or others if you're not medically trained. But I understand the frustration. Again, I've talked about this before. The conventional medical world, it doesn't know what to do with you unless you are sick. Okay, if you're sick, and you have a identifiable medical condition that they can treat, they can make you better, but they'll never make you better than average. And average these days is pretty bad. They don't know how to make you super healthy. If you want to be super healthy, the onus is going to fall on you. And there are physicians out there, there's other medical experts that have made that part of their clinical practice to help people get super healthy, like in that top 5%. Okay, that's something I like to do. I have an interest in because I want it for myself and I want it for you guys too. But yeah, it's frustrating. Your family doctor is just not going to be that interested in you know, in getting you into optimal health, because quite frankly, they're not in optimal health themselves. So how do you know when to go against the science and make yourself healthy? Uh, yeah, I don't know. It's a hard question. I hate the term like do your research, because you're not really researching. And most of the sources that people go to for information, like I mentioned earlier, are just garbage, and they're going to lead you astray, and they're going to lead you to believe all kinds of stupid stuff. Like it's okay to have an LDL of 500. As long as your HDL is high and your triglycerides are low, you won't get heart disease. Yeah, no, that's not true. But people believe that. So, again, it's be careful who you listen to. It's hard to find good information these days. I totally get it. How do I get my TRT doctor to prescribe Primo, Masteron, or Sust? I found plenty of doctors that will prescribe Test, Deca, and even Anavar. Yeah, there are clinics that will do that. I don't know why they do, but they do. I'm ready to level up. Careful what you ask for, man. So first of all, if you're in the United States, um, first of all, Primable and Masteron, they're no longer, to the best of my knowledge, these are not no longer made. And so all of your sources are going to be underground labs. Again, any of you steroid experts out there, please correct me, but they're certainly no longer FDA approved. I'm not aware of any compounding pharmacies that would make these drugs for you. Sustanon is available worldwide. It's probably the cheapest form of testosterone. Here in the UAE, they use a lot of Sustanon. They use a lot of undecanoate as well. So if you're in the US, they don't prescribe you Sustanon because it's not FDA approved. It's not available. I cannot prescribe Sustanon when I'm in the United States, let alone Primobolan or Masteron. Okay. But if you came to see me in the UAE, yeah, I could prescribe you Sustanon. It's not my favorite first choice for TRT, but you can make it work. So, but you're ready to level up, man. I don't know what to tell you. Yeah. You have to find it on your own. Okay, what are your views on supplementing with antioxidants as a highly active male on TRT? Do you take any yourself? Good question. So, yeah, if you want to be a purist, if you want to look at like actual clinical research on, supplementing with antioxidants like vitamin E and beta carotene, dude, it's poor. Like the data does not support routine use of antioxidants. Does that mean they're a bad thing? No. And do I take some? Yeah. Yeah. So I take a multivitamin. It has various things in it, like it has vitamin C, it has a little bit of vitamin E in it. So yeah, so I take antioxidants like that. But I don't take like mega doses of antioxidants, because like every single study that's looked at mega dosing antioxidants has not shown any benefit, and there's a few of them that have shown harm. So I wish it was different. Like I wish you could take a ton of antioxidants and slow atherosclerosis, and we know for a fact that that's not the case. So yeah, so not against you taking antioxidants. Probably not harmful, but not much benefit, at least according to the literature out there. So I don't go crazy with antioxidants. I'm 54, just CT done. CAC was 196. Okay, 165 in the LAD. Freaking out, but it sounds normal. It's common. You could argue whether that's normal or not, because it's more of a philosophical debate. Listening to this, it's just part of aging, like gray hair. Not kind of, but not really. Like nobody died of gray hair. Okay, lots of guys died of LAD plaque that ruptures. Yeah, so don't freak out when you get bad news like this. Come up with a plan. So you need to talk to a cardiologist. You need to, maybe even talk to a lipidologist. You need to address all of your cardiac risk factors. Okay, I would consider this a gift. You've been given the gift of foresight. So there are many men in their 50s that drop dead suddenly out of the blue with no symptoms at all because they have plaque rupture in their LAD and they never saw it coming. So you now have been given a little bit of foresight and warning. You've got a problem. So if you want to avoid the big problems down the road, you now have a golden opportunity to do that. So get with an expert in cardiovascular disease prevention, ideally a preventive cardiologist, address all of your risk factors to the greatest degree that you possibly can, and you'll be okay. Don't freak out. Just make a plan, execute. Question. Okay, great. This is such a good question. For men on TRT, how do we know that chronically elevated E2 is more beneficial to organ systems than a chronically controlled E2 level via AI use? All right, I'm going to kind of cop out on this a little bit because my good friend Keith Nichols is going to put together the definitive like talk on this. We're going to he's going to hopefully put the nail in the coffin. He's going to present all of this information at a future date here. He's been working on this talk for, I know it's going to be really good because Keith is a super detailed oriented guy. He is super evidence based. So we're going to lay out the answer to this question in painful and exquisite detail. I'm going to tell you why these clown influencers sitting in their basements telling you that you have to control E2 and it has to be a certain range in the serum don't know what the fuck they're talking about. And we're going to finally put together the definitive talk on this. So I'm going to hold off on answering your question, okay? Because I don't want to steal his thunder. He's going to do a much better job at this than I ever could. So just sit tight. Just sit tight. I wonder if being on a Nandrolone and TRT cycle going into surgery with general anesthesia would create significantly greater risk of a cardiac incident during anesthesia. Okay, great question. I'm on DECA and have an upcoming surgery. So, I mean, it could. Yeah, it could. I think I've talked about some of the rat studies where, the rats that were receiving, admittedly like pretty high doses of Nandrolone were more prone to cardiac arrhythmias. It was harder to get them out of those arrhythmias when they had Nandrolone in their system. So they required more like little shocks on their heart at higher voltages. Yeah, I personally, I would get that Nandrolone out of your system as much as possible especially if you're going under general anesthesia. It's, I mean, why? Like, what's the risk, right? Or what's the point of taking the risk? I wouldn't do it. That's what I would do. I would discontinue that. Nandrolone is problematic, man. It's problematic. I know it has its use cases. I know you guys out there with joint pain love it, but man, there's potential there, potential for badness. Okay, this is long. I'm not going to read the whole thing. Also, what is the real quote normal testosterone levels for men today? Considering a lifetime diet of processed food, the current and past vaccine schedules for babies, hyperfeminized societal pressure on boys and men, what is really quote normal today? I think we already know what's normal, and it's a much lower level than what naturally occurred 60 or more years ago. Yeah, that's true. Question is, what should be done about it? Apply a pharmaceutical band-aid over the symptoms of modern Weimar Western Civ, or have a revolution so we can entirely restructure our entire society? So listen, yeah, this gets back to like what's normal versus common or average, right? So what's common is not necessarily what's normal. Okay, so our population is getting more and more unhealthy, right? So it may become normal to be, or it may become the norm, average, to be the average man is pre-diabetic. That doesn't mean being diabetic is normal. Certainly doesn't mean it's optimal, right? So that's kind of where we're headed, where the norm or the average man is going to be hypogonadal, or like on the cusp of being hypogonadal. That's the average. So 50% of men will be well into the hypogonadal range. And then, the other 50% will be slightly above it, in a bell curve sort of distribution. That's kind of where we're headed. So the question is what to be done about it. Apply a pharmaceutical Band-Aid. Well, here's the thing, like you're never, let's say you have this revolution that you're talking about, which is never going to happen. All the microplastics and pollution, they're already out there, right? It's going to take probably centuries for that stuff to break down. So like 20 years after your revolution, guys are still going to have microplastics in their balls because it's still in the environment. Like, maybe it'll be less, but like a certain amount of damage has already been done. And, quite frankly, like, I don't get political on this channel, but, men, especially like American men, you guys are too fat, you're too lazy, and you're too lethargic to ever have a real revolution in this country, like a shooting war where you're going to overthrow the government. That's just fantasy. It's just fantasy. The average man in this country these days that would be of age, like to conduct a revolution, one, they have no training, no military training whatsoever, because they were too fat to even make it in the military. And they're too deconditioned and soft. I mean, they could barely walk like 3 city blocks, let alone like, hump an 80-pound rucksack and, engage in any sort of military operations to turn things around. That's that ship has sailed. So yeah, I don't know how we're getting out of this, but more and more men, I'm hoping will have access to TRT because they're going to need it. They're going to need it because that's just the way that we're headed. So anyway, enough on that. This one's kind of funny. All right. Hence why you take 250 milligrams of Nandrolone for 6 months, completely tank. This is okay. He's telling you how to get on, how to qualify for testosterone replacement therapy. Completely tank your natural testosterone production and come completely off Nandrolone and get a referral from your GP to go see an endocrinologist. Your endocrinologist will request blood work to assess your test levels. Your test levels will basically be 0 and you will qualify for TRT. Yeah, you could do that, but like endocrinologists are not stupid, right? They're going to see you rolling in there after being on Nandrolone for 250 milligrams a week for 6 months. You're probably going to have a reasonable amount of muscle tissue, and you're going to come in there with LH and FSH basically 0, and then super low testosterone. And you don't think they're going to know that you took androgens to get those kind of numbers? Like they're not stupid, all right? They're very bright people, okay? They're bright enough. They made it to medical school. They made it through an entire internal medicine residency, and they were smart enough to get accepted into an endocrinology fellowship. Okay, these are very bright people. They're going to figure this out. They're not stupid. So by all means, like if you want to go ahead and try that, see if you can squeak through. And I just don't know why you would do this. Like you don't need to do this to get on TRT, right? There's enough TRT clinics out there that will prescribe testosterone almost regardless of what your levels are, some of them. And so you don't need to do anything exotic like this. I have seen people do this to get their insurance to pay for it. In fact, I know of multiple clinics that have advised patients, they've put people on TRT and then deliberately took them off so they would test low so their insurance would cover it, okay? Which, by the way, is a crime, okay? That's insurance fraud. So if you run a clinic and you're doing that, you can go to jail and be fined for that. If your clinic is telling you to do that, that's a huge red flag. You're not dealing with an ethical operation, and I would turn around and leave. But yeah, so some guys do try this. I don't recommend it. Okay, we'll keep going here, guys. This is a long one. It's longer than I thought. This is what I get for not doing these more frequently. The questions start to pile up. Okay, do you have any content regarding treatment considerations for patients with, quote, normal total testosterone, 550, but low free testosterone, 3.5? Yeah. And a corresponding high SHBG. This is super common, right? This is super common. So, if you are symptomatic and there's no other reasonable medical or lifestyle explanation for your symptoms, a free testosterone of 3.5 is certainly low enough to possibly explain your symptoms. Yeah. And, assuming we've had a full conversation and I've done my due diligence and a proper workup on you, like you sound like you would be a candidate for a testosterone replacement. So yeah, and I think most physicians that know anything about TRT would agree. So you have an objectively low free testosterone level. Okay. Is sub-Q okay with testosterone cypionate in grapeseed oil? Yeah, it is. I didn't hear cypionate discussed in the video, so I wanted to try it. Yeah, of course. Yeah, grapeseed. For many years, I used grapeseed oil. You can do it. Some people get welts, and it can be an individual, reaction to different carrier oils. But grapeseed oil seems to be pretty well tolerated. So MCT oil is probably the best. That's the Cadillac. So if you can get that stuff, that's great. But there's nothing wrong with grapeseed oil. It's definitely cheaper. Good day, sir. Good day to you, sir. And thank you for the informative video. You're welcome. I thought I saw in another video you were going to cover why you wouldn't want to take Clomid while on TRT. Did I miss it? No, I've got a whole video on that. I saw another clinic post that I'm not sure, it's a typo here, Clomid was important. The HCG would cause the testes to be active, and then the Clomid would increase the production. Okay, I might be off. Yeah, a little bit. Yeah. I've also read that HCG can lower FSH. If so, is there a proper ratio we should be looking for HCG to HMG? Okay, I'll answer the last part of this first. So if you're not on TRT, you just take HCG, which is an LH analog, you will suppress your hypothalamic pituitary axis, and yeah, your LH and FSH will go to 0. So your FSH will go down just like your LH will go down. You'll be producing testosterone, you'll still be producing sperm to a certain degree, but yeah, your FSH will go down. Now, why don't you want to take Clomid while you're on TRT? I have a whole video that goes into details on this. It's that it's a sign of a really a bad provider, a bad clinic if they do this to you. Okay. So the reason that this became popular is when HCG, when it could no longer be compounded, right? We had a shortage of compounded HCG, and like there was a shortage of, pharma grade like Pregnil. So clinics couldn't get HCG. So they said, oh, well, we'll put you on Clomid, and then we'll be able to maintain fertility just like we did on HCG. And that's just not how the HPTA axis works. Okay. Um, I have seen this with patients. In the video, I tested this on myself. Okay. If you are on a reasonable amount of testosterone for your TRT protocol and you take Clomid, okay, your LH and FSH will stay at zero. They will stay at zero. You will not regain fertility, despite what these clown clinics say. And it's shocking to me, like there's still clinics to this day that are prescribing either clomiphene or N-clomiphene with TRT in order to, quote, maintain natural production. No. If you don't believe me, go check if you're on one of these protocols and you're taking, anything north of like 120 milligrams of testosterone a week, go check your LH and FSH. It's going to be zero. Okay. It's the blocking of estradiol at the HPTA that clomiphene and N-clomiphene do. You can't, it's the testosterone, it overrides that. The testosterone is suppressive in and of itself, as is the DHT. It overrides any effect of blinding the pituitary and the hypothalamus to estradiol. You're not going to get a meaningful, if any, rise in LH or FSH. So how do you know you're at a bad clinic? How do you know your provider skipped endocrinology day at a medical school? Is when they put you on Clomid or N-clomiphene while you're on testosterone. That's how you know. All right. Okay, this is a good question. So again, I need to do a whole nother video on this because these are deep questions, and like my ability to be succinct is challenging, especially when I'm tired. Hey doc, I'm not getting libido or erections on TRT. Okay, that's a problem. I'm not taking NAI. That's good. I recently bumped dose up to 250 milligrams per week to see if that would help, but no luck so far. Prolactin and thyroid is fine. Okay, good. I'm glad that was checked. Should I take an AI? No. What do I do? Okay. I'm going to give you generic advice. I don't know you. I can't give you formal, like individual medical advice, obviously, in these videos. 24 years old, in shape, and no vascular issues that you know of. First shot or two, my symptoms resolved, but always come back once on a consistent dose. Please help. Okay. So this is like, here's the thing. Erectile dysfunction, despite what you might hear on the internet, is very complex. Okay. Even as at 24-year-olds can have ED, and this requires like a proper medical evaluation, a proper visit, and a good detailed history and physical exam. Okay. It's not what people want to hear. It's not because your E2 got too high on testosterone. That's not the reason. Okay. It's okay. There's a lot of reasons why you can have erectile dysfunction at any age, but especially at 24. Okay. The psychogenic stuff that's a real thing. Okay. Like every man has had that at some point. You get stage fright, you get anxious, you're with a super hot, new partner, and like it just ain't happening. Right. Okay. That's psychogenic. Okay. That happens. And for some guys, especially younger men, that's usually the most common cause. Right. So that's something you got to look into. Right. So, the questions I have for if somebody comes and sees me and they're suffering from ED, like, after taking a full thorough medical history and evaluating them, are you getting nocturnal erections, right? Okay. If you're not getting any erections at night, that's pointing more towards an organic cause. Okay. If you are, then that's good. It may point towards more of a psychological, or psychogenic cause. Is it situational, right? Like I had no problems with my ex, but now that I'm with my new girl, now I'm having problems. Or now when I was married, I had no problems. Or when I was married, I had problems, and now that I'm not married, I don't have problems. Like, is it situational, right? Or can you get an erection when you're masturbating, watching porn, but not with sex? So that's becoming an increasing problem. Like, porn like rewires your brain, especially like young men should not watch pornography, in my opinion, or keep it to an absolute minimum because it really screws you up mentally. It really can screw up your ability to have a normal erection with a normal partner. Okay. So that you can't discount that. Okay. You already mentioned your libido is not good. Well, again, libido is multifactorial. I need to know a lot more information other than, um, what your testosterone dose is. Okay. Medications. Are you taking any even over the counter medicines that could be contributing to this? There's a lot of them. Like guys have no idea. Like antihistamines can cause erectile dysfunction. Okay. Nasal decongestants, can cause erectile dosage. High dose, if you're taking NSAIDs, right? Like ibuprofen, high doses on a continuous basis, like we did in the military, can cause erectile dysfunction. And most people don't know that. There's a whole list of medications that can cause erectile dysfunction. So, are you obese? It says that you're in shape. Okay, cool. So I'm going to assume you're not obese. Get a DEXA scan. I can't tell you how many guys have told me that they're in shape, and I throw them in a DEXA scan and they're 25% and above. Okay, 25% is obese, by the way. Okay, by DEXA scan. If you have a body fat percentage of 25, you're obese. If you are obese, and even if you're not obese, even if you're above like north of 20%, that's obese enough to lead to and cause endothelial dysfunction. Okay, so that's one of the it's actually a primary driver of erectile dysfunction. When they can't find any obvious other cause for it, body fat percentage, endothelial dysfunction, you have to have high amounts of nitric oxide in very healthy, smooth muscle in all of the vessels and the penis itself. Some vessels need to constrict down really tight, others need to dilate. So, and if you have a problem with that related to poor nitric oxide production because you have all these inflammatory cytokines from being overweight, you're going to have poor erectile function, right? Do you smoke or vape? Like vaping is terrible for you. A lot of guys your age vape. If you're vaping, you need to cut that shit out. Okay. That definitely leads to endothelial dysfunction. Okay. Trauma. Have you had trauma down there? Like physical trauma from sports, you'd be surprised. You might have a vascular issue. Even, like you can have what's called pelvic floor dysfunction. Okay. Where you have improper contraction and relaxation of the pelvic floor muscles, right? It can limit blood flow through the arteries and the veins down there. And that's a diagnosis that needs to be made at a specialty center. There's ways to look at that, but like the dummies out there on the internet will tell you that, bro, it's just your estradiol. The fact is, like, evaluating erectile dysfunction is very complicated. You need to take a thorough history. You need to look at all the parameters. So I can't fix your problem here on this video. You need to see a doctor, see a urologist or andrologist or like a really good internal medicine or family medicine physician who has experience with this stuff, and get a proper workup done, and see what they can do to help you out. Don't try to solve this on your own. Okay. Or like, for God's sakes, like don't go on YouTube and try to solve it, and go on Reddit, because you're going to get some really bad advice from people. Okay. Erectile dysfunction, especially in a guy your age, is usually fixable. It's usually fixable. Where it's not fixable, and this is what I see in my guys, an older population, once you get atherosclerosis and you've gummed up your pudendal and penile arteries and you've got plaque there, and now there's no flow, you got no blood flow because you've got atherosclerosis. Now you've got real problems. Like that's now some of those guys need to go in, and the only answer for them is a penile prosthesis. Which, trust me, if I've scrubbed into that surgery a few times, and I would not want to get one. Although I hear some guys, the satisfaction with the penile prosthesis is very high from what I hear. So maybe I shouldn't be so judgmental. But anyway, yeah, please, like, go see an expert, and actually not a self-proclaimed expert, right, with a YouTube channel, but somebody who actually has done a urological residency, okay, who actually is a physician who knows the ins and outs of erectile dysfunction. That's my recommendation. Okay, I think this is almost done here. All right, this one was related to, like, it's an older video on like colognes and perfumes and like all the endocrine disrupting compounds that are in there. This guy must stink. No soap, colognes, or hygiene products. You do you, quote, doctor. Okay, yeah. I love it when you refer to me as doctor in quotes. Okay, thanks. Dude. All right, just because I'm warning you about phthalates in cologne, like, doesn't mean I don't practice personal hygiene, right? There's a lot of hygiene products out there you can find that are like, quote, natural and organic, that don't have these artificial chemicals in them that are going to tank your testosterone. But hey, man, you do you as well. So if you like to use male perfume, which is what cologne is, and you don't care about your endocrine system, yeah, man, go for it. I don't care. Just don't spray that shit around me. Just keep it away from me. I don't want that anywhere near me. Okay, final one here. This is actually a great question. I've talked about this in other videos. Daily 81 milligram aspirin, beneficial for those who are at a higher risk of a cardiac event? Question. I know it has possible side effects. Yes, it does. But in that population, is it typically advisable? Thank you. You're welcome. Okay. So yeah, excellent question. So the use case for aspirin, like it's really been narrowed down over the last few years. I remember in my residency training, this was kind of like a daily baby aspirin, like 81 milligrams was kind of like a blanket thing that we just sort of recommended to most men like over the age of 50. And that's definitely not the case anymore. They've really, like the American Heart Association and the U.S. Preventive Services Task Force, as a result of like some pretty big studies over the years, have really like curtailed their aspirin recommendations when it comes to primary prevention. So you haven't had a cardiac event, you want to prevent that, that's primary prevention. So they're saying basically that they're limiting it to younger guys, so age like 40 to 59 is typically what they talk about. Although I think the American Heart Association, I think they go up to age 60 maybe or 70. I can't remember. I always just use the U.S. Preventive Services number. So 40 to 59. They have a 10-year ASCVD risk factor calculator. So you plug in your numbers. If it's more than 10%, then yeah, maybe you could be a candidate for aspirin, assuming you don't have any contraindications to aspirin, like, anaphylaxis or like, peptic ulcer disease or like some other, hematological bleeding condition, like assuming there's no contraindications, and that would be like a benefit outweighs the risk scenario potentially. But even then they say like have that conversation. It's an individual decision between you and your doctor. And over the age of 60, it's not recommended at all in most cases for primary prevention. And I think it's 70 for the AHA, if I remember. So basically like it's that middle age zone. And then once you start getting elderly, the risk of having a major bleed outweigh the potential benefits of, lower heart attack or stroke risk. This is for primary prevention. So, and that's even if you have diabetes. Like it used to be diabetics kind of, we always were like, yeah, you should probably be on aspirin because you're at high risk. Like if you just have diabetes and you don't have other major risk factors, they generally just will kind of steer you away from that. So now if you have, there's some caveats to this. You have no other risk factors, you're in this age group, but let's say you have high LP(a). So that's kind of an area of controversy. There's a lot of cardiologists that would recommend, because LP(a) is so bad, that maybe you should be on a baby aspirin every day. I actually take a baby aspirin every day because of my high LP(a). It's not a hard recommendation. And, I don't mandate that for my patients. We just have have a conversation about it. If you get a CAC scan, like calcium score, and it's greater than 100, there's probably an indication to at least have that conversation, because that means you have a significant plaque burden. I think it's if it's over 100, like 100 to 400, I think is, I don't have this in front of me. If it's 100 to 400, it's strongly consider. And then if it's above 400, then you probably should be on aspirin, if I recall. I guess correct me if I'm wrong on that. But yeah, generally, if you have, high calcium score, probably should consider, even though you haven't had an event yet, you should consider being on a baby app. Now, there might be some other like indications outside of the cardiovascular realm. So like people with high colon cancer risks, or like these hereditary polyposis syndromes, they will sometimes recommend baby aspirin for them. My wife was put on baby aspirin late in pregnancy for preeclampsia prevention. So our OBGYN friends will use it. I know that doesn't apply to you guys on this channel, but just think there are other indications for being on aspirin. And then, secondary prevention, that's a different ball game. Like if you've already had an MI, especially if you've had a stent, if you had a prior stroke or a TIA or a CABG, bypass surgery, oftentimes the recommendation is lifelong, low dose aspirin. Many times you'll be on what they call dual antiplatelet therapy for a period of time after you've had a stent placed or after you've had a CABG, and then they'll take away the second drug, which is usually ticagrelor or clopidogrel, Plavix, and they'll just leave you on the aspirin, for the rest of your life. So if you're in that category, then maybe aspirin. But when it comes to TRT, what's not an indication is just you have a high hematocrit. I've seen clinics do that. I've seen a lot of guys like on their own. They're like, well, it seems like a good idea. My hematocrit's 53, so I don't want to get a blood clot. So I should take baby aspirin every day. There's no evidence that that is going to help you in any way, and it actually might end up being harmful. So. Okay, that's it, guys. That's all the questions. So I hope you guys got something out of that. Please keep these questions coming. They're great. These are really good questions. I appreciate them. I will catch you guys next time. I'm gonna go have some lunch. Bye. All Man Medicine video and audio has been created and shared online for informational purposes only. This podcast does not constitute the practice of medicine or professional healthcare services of any kind, including the giving of medical advice. I am not your doctor. No doctor-patient relationship has been established. This content is not meant to be a substitute for professional medical advice and should not be relied upon solely for that purpose either. The only purpose of this content is to present peer-reviewed, research-backed health information for your consideration. As always, rely on the advice and guidance of your personal physician before undertaking any activity presented here, and if in doubt or not comfortable with said activity, practice discretion. Your health is your responsibility and not ours. Finally, I take conflicts of interest seriously. I accept no compensation whatsoever from any private corporations, including pharmaceutical or supplement companies. You can trust that if I recommend a medication, product, or service, it's because I genuinely believe in it and not because I'm being paid to endorse it.